CLL remains the most common leukemia in adults, representing about 25% of leukemia diagnoses, and because of its prevalence, there's been a lot of innovation in the therapy for CLL, initially with a combination of monoclonal antibodies and cytotoxic agents we call chemoimmunotherapy, and those regimens have been standards of therapy for a number of years, but we recognized that there were patients that have certain cytogenetic abnormalities, such as 17p deletion abnormalities of p53, who just didn't benefit well from those types of chemoimmunotherapy approaches. And fortunately now we have a number of targeted agents that hit various Achilles heels of the CLL cells, including BTK inhibitors like ibrutinib, BCL2 inhibitors like venetoclax, and PI3 kinase inhibitors like idelalisib, that have demonstrated single agent activity even in patients that carry some of these high risk features such as 17p deletions, as well as the immunoglobulin heavy chain unmutated patients, which represent a higher risk subgroup of CLL patients. And so now we have a number of studies that have demonstrated activity of these agents in the front line. Ibrutinib, of course, is approved for patients 17p deleted or not in the front line and beyond. Venetoclax is approved for patients that have 17p deletions after at least one therapy, but there are ongoing studies to bring these more and more to the front line, and some of the studies that were reported at ASH, or at least mentioned at ASH, are looking at direct comparisons between novel agents like ibrutinib versus chemoimmunotherapy approaches, because I think one of the most difficult things when we see a patient with CLL is to determine, should we give them a novel agent or should we give them chemoimmunotherapy? And right now we're by and large making those decisions out the context of a strong evidence base, but these ongoing studies are going to lead us in that direction.